good evening. My name's Katie McClure and I'm here with my colleague from BCS, British Computer Society, Health and Care Scotland, Sharon Levy, who's the current treasurer, and we're both long-term committee members, and we take the heavy lifting with getting all these talks organised. This one's a pleasure because it's from DigiFest24, which was at the beginning of December last year, and we had the most high standard we've ever had for the poster abstracts. With nearly 50 submissions, and the standards were just exceptional. And I think you'll see why when you watch these this evening. You don't need to be a British Computer Society member to come along to our talks. It'd be lovely if you do join. And if you'd like any more information on that, you can ask myself or Sharon. Just pop your details in the chat. This is being recorded. It will go up on the website, the BCS website, and it means that the authors and presenters can then link it to their own pages as well. And we really appreciate your questions as we go along. So each presenter is going to have up to 10 minutes, and then we look forward to a few minutes of questions after each one straight away. So but you can post your questions in the chat, or if we're a small select audience, you might want to come up with your camera on and microphone and speak to us. But do remember it's been recorded, so it's up to you if you want to get involved in that side of it. Each of the presenters will introduce themselves, and you can see the titles and you can see where they're from, or they'll tell us, and I'm really looking forward to it. We've got 4 great presenters tonight, and I'll give you a link to a 5th one who couldn't manage along tonight. But with that, I'm going to hand over to Jen. So over to you, Jen.
Thank you, Katie. Hi everyone, good afternoon. I'm really happy to be here and just to tell you a little bit about our Illustrum 2 project. So I'm just going to get straight into it and set the scene really. So I'm not sure how many of you know about kind of sexual health and STIs, so just to get everybody kind of on the same page to begin with. So each year, over 410,000 people are diagnosed with a sexually transmitted infection or an STI in the UK. STIs can cause long-term health consequences, and so it's vital when someone is diagnosed, and this person is called the index patient. It's not only vital for them to receive treatment, but also for us to try and identify, notify, test and treat any of their sex partners. This process is called as contact tracing, or it's sometimes referred to as partner notification, and it can prevent onward transmission of STIs to other people, as well as prevent reinfection of the index patient, the person that was originally diagnosed. So effective contact tracing is even more important in the era that we're in just now of antibiotic resistance, which is making some STIs much more difficult to treat. And our Illustrum trial showed that only half of sex partners actually tested. So we felt that sex partners might therefore benefit from help to get tested upon being told that someone they've had sex with has a sexually transmitted infection. So we applied for and were successful in getting funding to co-produce short films to encourage and support sex partners of people with STIs to get tested for STIs and HIV. So this is known as a full sexual health screen as part of contact tracing. And in terms of who we're trying to reach with the films, so young people, and particularly young people of Black Caribbean heritage, are disproportionately affected by STIs. So we sought to create up to 2 tailored and culturally sensitive co-produced films that co-producers and their peers could take pride in. We also felt it would be worthwhile to make a 3rd informational film. And this would be more for a general audience, so kind of broadly applicable to everyone rather than targeted at kind of key populations. But we would do this through consulting public contributors rather than co-production. And so today I'm just going to focus on the co-produced films, films 1 and 2. So what is co-production? You may or may not have heard of this approach before. Oh, I'm getting a notification to restart my computer. Let me snooze that. So yeah, co-production, it's an evolving field, and it's generally understood as an approach that emphasises the importance of sharing power to promote inclusive research practices. valuing and respecting different sources of knowledge, and also the importance of trust and relationship building over the course of a project. So it's a way of ensuring that any interventions that you developed are not only based on evidence, but also that they're practical, acceptable, and also owned by the kind of target population. And meaningful and authentic co-production requires a significant time and financial investment, and that's to reimburse co-producers for their contributions that are highly valued in line with the involved guidelines that are set by the NIHR. So co-production was a very new approach for most of the research team, and in recognition of this, we undertook training delivered by UCL's Co-Production Collective, who support co-production within research, policy and practice. The training was used along with guidance from our funder, the NIHR, as I mentioned, to help us just develop this kind of insight to co-production as an approach and a mindset. So a very different way of working. We drew on pre-existing principles for co-production to devise our own projects, principles and ways of working. And then we created work plans, and this included an evaluation framework for discussion and refinement with co-producers. I don't have time within the presentation today to talk about the evaluation, but I just want to flag that it's an integral piece of the work that shaped what we do over time, and hopefully will be helpful to other people who want to engage in co-production moving forward as well. So in terms of identifying and inviting co-producers to join the group, we advertised using flyers, initially hoping to convene one group that could co-produce a film for young people, ideally with slight overrepresentation of young people of Black Caribbean heritage, to ensure that this often underserved and unheard population was well represented and considered in the young person's film, but also with that option to create a kind of specific targeted film for young people of Black Caribbean heritage, if that was decided by the group. So very much being led kind of by the group. And the original young persons group did provide us with a clear steer on that. So they noted the need to expand the group to get more input from young people of Black Caribbean heritage. And eventually we actually kind of settled on devising a completely new action plan to convene a second dedicated group for a targeted film for the young people of Black Caribbean heritage. So recognising that they're a key kind of subpopulation among young people. So we worked really hard, I've got to say, and it took quite a bit of time to convene two diverse groups to co-produce the films. Both groups in the end included people of different sexual orientations and genders, and they had varying kind of experiences of disability, illness and neurodiversity as well. Our co-producers are located throughout the UK, and they've drawn on their wide-ranging kind of lived experiences as well as their educational and professional backgrounds to be able to input throughout the co-production process. And moving on to the co-production process itself, so this was actually the same process like for both groups. And here on the screen, the text in the circles just basically summarises kind of topics that we covered within online workshops. And it was all online because everybody was so kind of spread out across the UK. And then the outside activities just relate to activities that were conducted remotely by individual co-producers or sort of more small group meetings out with the main workshops. Notably, the workshops for young people of Black Caribbean heritage, they were co-delivered in the end with two Black Caribbean co-producers from the original young persons group and our lay co-investigator who was Black identifying. And this was in recognition of the importance of having a Black-led space. It was really great to actually end up working with some of our original co-producers in that way. It was not how we'd kind of expected in the beginning, but it was really nice that that's how it ended up. So basically through the kind of completed workshops and the activities that we did prior to filming, the groups kind of got to know one another and agreed different ways of working. They discussed barriers and facilitators to STI and HIV testing. They decided on film concepts, settings, characters and messaging, and they developed the film scripts. And they also took part into evaluation surveys as well prior to filming. So we recently completed filming and we hosted workshop 5 with each group last week, during which we discussed the first cut of each film, any kind of changes that might be required, and possible dissemination routes as well. So just in terms of the kind of films that we've created, I just wanted to say that I think through creating a safe space, both groups were actually able to engage in kind of very open conversations around sexual health, which is a very sensitive topic for a lot of people. There's still a lot of stigma and taboos related to discussing the gender, sexual orientation, sex and STIs. So I think as a group, we did manage to kind of break any barriers that there might have been, and obviously some of the people I think that were involved, it was always advertised as being a sexual health topic, so some people just self-selected into that, but we did try and make you know, the participation as accessible as possible in terms of you can participate with your camera off, or you know, allowing anonymous contributions through kind of anonymous group chat things as well. So we did kind of stretch things so that, yeah, everybody just felt like they had that it was that safe space. So in terms of the films themselves and the film brief, both groups opted for a live action film over animation. They really wanted to challenge that stigma that I've just spoken about, and to show different scenarios that would highlight different relationship types between partners, different ways of finding out about an STI exposure and reactions to this, different views as well and reasons for STI and HIV testing, and of course different ways to test and signposting people to find out more information about what's available to them locally. Both groups suggested similar film settings, but there was definitely different cultural references suggested to shape like set design, costumes and dialogue as well. And while there was overlap in the key messages that could be conveyed, the young persons group kind of uniquely focused on trying to convey that STIs are common, so the commonality of STIs, the importance of taking care of your own sexual health, but also the consequences, interestingly, of STIs for other people. Whereas the young persons of Black Caribbean heritage group, they spoke a lot really about negative emotions and that emotional aspect, especially anxiety and fear about receiving a positive test result and what that might mean. And they felt that the film should prioritise this, as well as inform that prompt testing and treatment can prevent STIs being passed in this kind of back and forth way in ongoing relationships and concurrent relationships as well. So I just wanted to give a little bit of feedback that we've had now from the co-producers of each group. So this is just a screenshot from one of the scenarios that's depicted in the film for young people. And when we asked our co-producers how they felt upon seeing the films for the first time, one of our co-producers in this group said, "I felt empowered watching from the lens of someone with no background info on STIs and the importance of testing. It taught me a lot and made me feel educated." So that was great. And then for the film for young people of Black Caribbean heritage, one of our co-producers there said, "I feel so happy. STIs are so stigmatised, and seeing it in such a positive light with so many Black and brown people is amazing. It made me emotional, making me realise I've never seen this representation before." So it was actually a really emotional fifth workshop that we had, where everybody just felt so positive and kind of like really happy with the films. So I think for us as a research team, that was a lovely moment to, because it had been tricky working in the co-production kind of way. It's a different way of working. So I think it was a real kind of pat on the back, thinking, okay, we've actually managed to do something quite special here, I think, and hopefully when we disseminate the films more widely, other people will agree. So moving on nicely now, that just brings me to the next steps. So we have been in a very kind of fast-paced phase for the last sort of month and a half, and the study closes at the end of this month. So we had been continuing to work with our co-producers in post-production, and that is pretty much wrapped up now, and we will receive the final films actually tomorrow. And tomorrow we will close our summative evaluation as well. So we've got a little bit of analysis kind of outstanding for that to do. In June, we've been invited to launch the films and an implementation toolkit at our clinical sector conference in Edinburgh. And the films will be adopted by the British Association for Sexual Health and HIV for use in online and offline STI clinical care pathways. Thinking about the future, well, we've also been exploring kind of wider dissemination as well in terms of like social, community and educational settings, but the kind of principal aim, first of all, was for these to be used in clinical settings, so that when people are in that moment of feeling maybe a bit overwhelmed or like a range of emotions, finding out someone you've had sex with has got an STI, they can view these films and hopefully feel a bit better, know that they're not alone in it, and know the kind of next steps available to them. But yeah, in future, we might also like to explore just how the films have been deployed, how they've been used by people, reactions to them, and what measurable impact they might have on sex partner, STI and HIV testing. So just to finish up, thank you to everybody on this slide, especially you today for listening, and of course our co-producers as well. And I'm very happy to take any questions if anyone has any. Thank you.
Wonderful presentation, Jen. Thank you very much. That was absolutely excellent. My first question is that the co-producers that were involved, were they the actors in the films?
One of them was.
Yeah.
So we didn't seek out young people that wanted to act specifically. We did seek out young people from a range of backgrounds. One of them had a lot of scripting kind of experience, and so they led the scripting with input from the group. But a couple, in fact, I think it was just one person. Yeah, it was one of the girls in the young person's group, the girl that's on the screen actually. If I go backwards, this is one of our producers, and she was really keen to be involved, so she did, and she came along to when we were filming in London. She came on set. She brought all her stuff with her, all her, you know, she was really excited. And trying to think, she's got a line in the end. She wasn't meant to have a line. It was meant to be, she was meant to be like texting with all of her friends throughout.
Okay.
With kind of interspersed with the other scenarios. And so, yeah, I think that was something that we felt like we could give back to her as well, because for her that was really important. And we've actually been able to link her up with the film production company, who have got opportunities, for young people from kind of minoritized communities, for some work experience. So that's been really nice.
Yeah, I think that's tremendous that you've been able to do that. Yeah, definitely. Sharon, you've got a question?
Yes, just to follow on the idea of the actual humans playing the casts rather than, say, personas. With the advent of AI and the development of such technology, do you think there is a way of embedding the co-production and creating the script and then getting machines to create the films? I'm just thinking about costs here. Do you think, on reflection, that cost could be saved by using technology in the future?
Do you mean technology to write the script, like the AI?
So the script could be co-created with your co-producers, but the actual film could be produced by AI. That's what I'm thinking.
I mean, it's probably the way things are going, isn't it? AI can can potentially do all sorts. I feel a little bit unsure about that though, because what happens to the people that work within the film industry? And maybe I'm not understanding your question properly, but the role for like actors themselves and like the young person that was able to actually have that experience of being on a film set, etc. But AI could take us in all sorts of places, and it is taking us into all sorts of places.
Thank you.
A point from Nessa, she's asking if your dissemination is including going out to likes of NHS Inform, Young Scott, and so on. But I'll leave you with thinking about that one, because we're going to move on to Abdu's
Okay, I'll write a little message to this one. Thank you.
Okay, should I share my screen? Okay. Hi everyone. Okay, before I start sharing my screen, thank you so much, Katie, Sharon, Claudia, and Nisa for having us and giving us the award. That was meaningful for me, and I believe my colleagues as well. And thank you for my colleague for joining us for joining today. So let me share the screen quickly. Yeah. So can you guys see the screen? Yeah. So
Yes, looks great.
yeah, so basically, before I dive into this, the details of this, I'll quickly summarize the story behind all of this. So where all of this came from and what's the idea. So the app is called Food Map Guru, a digital health solutions for IPS management. Before I dive into that, everything started from COVID. Right after COVID, when there is a lockdown, we all actually, in home with not proper kind of exercising, and sometimes you go and eat not so proper food, and then that will cause basically disorders when you eat and don't exercise and don't move and things like that. So I remember I did have some eat a lot of biscuits at that times, and that caused some pains in my abdomen, and I haven't experienced such pain before. And fast forward, I'm going through multiple kind of visits to the to the GP, further kind of assessment, and multiple kind of appointments. I pretty much wasted the time of the NHS going through this, but eventually one of the GPs, when the results all came out, they told me you experiencing something similar to the IBS, or the IBS, and but they are not sure about it. And the GP suggested me to go and test the low food map diet. This is some sort of a diet that is created by Monash University in Australia, and basically to eliminate specific carbohydrates in order to see which one is causing the issues, and then eliminate them or replace them, basically. So, and then after the GP told me about this specific diet, I went outside and looking, Googling what I can use as a software or a system to help me, and I found many apps, but none of them actually was appealing enough or user friendly enough. And this is why I thought maybe through the master study I can come and create a solution. It's not only about the technology, it's about the people and how they feel, how they can use something to minimize the challenges of the adherence to these kind of apps. So this is why I've created the Food Map Guru. Is an master research app, is a prototype basically. And when we go to the this is the ePoster. When you go to the ePoster, you will see the different kind of aspects here. One of them is abstract. The abstract basically tells you in a broader context what the IBS is, and who is affected by it, and what kind of issues or challenges coming with it. And then you will also see the method I have followed to develop this software. So basically, I follow the double diamond design framework combined with other kind of methods, quantitative, qualitative kind of methods, and all of them. And also, it's not only these kind of methods. Also, there is a market review. So I've gone through multiple apps within the market and reviewed them all in order to come up with some kind of criteria as well. So these all informed into some sort of findings and data, and that's strengthens the findings by interviews with actual patients or people have IBS, and then we all together worked and co-produced this kind of solution. And as you can see here, some of the steps we have taken to create to market review the existing apps, and also the double diamond. And basically, I follow the discover, define, develop, deliver, all of these different phases for creating the app. And the result is, so although one of the limitations is to have enough participant, because due to the limited time of the study, but I've managed to have quality of input from the users who actually managed to finish the study with myself. So 91% on the scale of the system usability scale, and that's high compared to the other apps that we had, and all back to the fact this is not about the technology. This is not about the design and the shiny kind of colors here. It's all about we work with the users to create something for the users, and that's one of the things I've learned through this. And yes, Monarch University, they have their own kind of app they've created for the low-fold map, but this supersedes their kind of application in terms of the usability, in terms of the different kind of things it has. So what things that added within this app? So basically, user has personalized dietary support. They have symptoms tracking, educational resources, and many other things. And why that's matter? Because the low food map itself is not an easy kind of process. So you have to go through different kind of process or steps. So the first step is to eliminate 2 to 6 weeks. You have to eliminate these carbohydrates, and then after these 2 to 6 weeks, you have to reintroduce them to see which one is causing the issues. And then when you found the one making the issue, then you have to come and then find a replacement for it. So for example, if you find onion causing you troubles, then you have to replace it with carrot, for example, or these kind of things. And this app is designed to help you on that, and also to capture symptoms, to learn more, and then track the progress and see the charts and the overall kind of feelings and capture everything basically. And it has also the option to, because all of this from the user perspective, but you need the professional kind of feedback or guidance around it. And there's an option for integrating a professional dietitian or hospitals or NHS to come and then provide support for the users. So this is the app in brief. And yes, and if you have a link to this, you can also go through the prototype itself. You can click on this and you can basically see the prototype. It's an interactive kind of prototype that you can experience. And yes, that's in brief everything about the FoodMap Guru app.
Thank you, Abdu. That was brilliant. And it was a piece of research I was really impressed with when I saw it the first time round, and one that I'm encouraging you to look for PhD opportunities. So I hope you're having some opportunities coming your way. Is there anything happening?
Well, I have an interview next week.
Oh,
yeah.
Everything crossed for you.
For a potential PhD.
Excellent at it.
Yeah.
Sharon, did you put your hand up there?
No, but I was impressed with the user-centered design methodology, the double diamond and everything. How did you find working with the ethos of user-centered design? Was that something new to you, or something that you've done in previous studies?
I would say it was new for the scale I worked on, right? But it wasn't new entirely, because I used to work as I'm a project manager working in the public health Scotland, and prior to that, for 10 years I've been working as a project manager. So I always worked with users and had involved in workshops and different things. But making it a bit systematic like that and having frameworks and things is new to me. But it's actually something I learned from it, because right now in my workplace, I'm using some of these kind of learned things to improve the products within the workplace as well. So yes, new in terms of the way we have handled it, but yeah, I do have some sort of experience prior to that. Yeah.
Fabulous. Well, I hope you'll let us know how you get on, please.
Thank you.
And I'm sure if that one doesn't work, keep trying. There'll be other opportunities, I'm sure.
Will do. Thank you so much.
Miriam, can we go across to yourself, please?
Yeah. Just a second that I share my screen, and here. And here I am. Can you see the screen?
Not yet.
Yeah. Sorry, can you see?
No, not yet.
Allora, and I'll show. Sorry, Sorry, share. Okay, share. Just a sec. Oh my God. Sorry, I made a mistake here. Stop sharing it just a sec.
No problem.
Sorry.
We could see how busy you are.
No.
I've just posted in the chat where you can get a look at all the ePosters from DigiFest 2024 in Learning Toolbox, and you can catch up with that on your Maxwell's one there too as well. It's been a brilliant platform for posters over the years, as I'm sure Nessa would agree.
Yeah, initially we didn't think people would really, well, we weren't sure if people would engage with it, I think it's fair to say. It was quite a departure for us. And if
Can
it
you
was,
see the poster now?
it works.
Yes, we can see it. Thank you.
Okay, so I can do this. Okay.
Lovely.
Sorry
Looks
for
great.
because
No, not at all. Happens all the time.
Okay. Thank you very
And you
much.
go then.
For giving me the opportunity to present again the code. The code is a user-friendly digital platform that we have developed and stands from distant evaluation of cognitive deficits. We have developed this kind of platform to address an existing problem within the healthcare system, within the NHS. And the current problem is that we have an increasing number of migrant patients. And these migrant patients, sometimes they don't speak English, they don't speak the language of the host country. So it's very difficult to assess the healthcare needs of these patients because there are very serious language barriers. So the patient doesn't speak English, the healthcare professional doesn't speak the language of the patient, so it's very difficult to carry out healthcare assessments. In particular, we were interested to the assessment of cognitive deficits or healthcare issues, mainly dementia in some older migrants. And this is again very difficult because it requires a certain type of engaging a certain type of conversation and using a specific cognitive test to diagnose the disease. So the current practice to solve this problem, the language barrier, is for the healthcare professionals to use professional interpreters, translators. However, these translators are usually quite costly, so they are expensive. And in particular, they lack the relevant knowledge or expertise to carry out an assessment of cognitive deficits because they need to engage in a certain type of conversation, and in particular, they don't know how to use cognitive tests. So this is far from being optimal. Also, another problem with interpreters is that while interpreters for common languages are easy to find, interpreters for all type of languages spoken by migrants are more difficult. So we propose a different solution. We thought that we develop a user-friendly digital platform to connect healthcare professionals that speak different languages and have different cultural backgrounds. So this, through the code, through the distant evaluation of cognitive deficits platform, we can connect health professionals that they can conduct remote assessment of cognitive deficits in a patient speaking the patient native language, and in particular using culturally validated tools during the assessment. So this platform has been developed in a way in which, for example, an health professional in UK can identify a colleague that speaks the language of a patient, think that he needs to assess a patient that speak, I don't know, Polish, and the health professional doesn't speak Polish. So they needed to identify, so they can identify through the code an healthcare professional in UK or abroad that speak Polish, and they can conduct the assessment of the patient remotely through the code. They can organize the appointment, they can do the assessment, and they can upload the result of the assessment. So this is a very efficient way to carry out a remote assessment and to improve the diagnosis of people that speak, that they don't speak English but speak other language is a more efficient way because it requires less time and of course save money for the NHS because you don't need to involve professional interpreters. We have conducted a series of pilot studies using the code, and the result of these pilot studies has been very positive. So the people that they have used, including health professionals that they have used this digital platform, they found easy to use. They were very satisfied and happy to use the platform, and also they show a positive support for the initiative because they thought that is a very good initiative, a very good solution to connect healthcare professionals from diverse linguistic and cultural backgrounds. So just to conclude, the code is a user-friendly digital platform that offers the opportunity to improve quality of care for disadvantaged and underserved population, and in particular it can improve the diagnosis of cognitive issues in migrant patients in the UK. Thank you.
Wonderful, Miriam. Thank you very much. Really interesting. And it was your colleague, your co-author, Sergio, that presented at DigiFest. He did it quite a different way. He just had an object and he spoke, and it was really quite engaging as well. But it's such a powerful subject matter to focus in on. How did it come about in the first place that you thought to go there?
It's just because this is a collaboration between University of Aberdeen and University of Edinburgh. It's just because I work in the Aberdeen Centre for Evaluation, and I work with clinicians and in collaboration and talking with mainly neurologists and people that they were involved in assessment of patients with dementia in different countries, because we were actually at a conference abroad, and everyone from different places, they said, oh, we struggle because it's difficult to assess people that they don't speak the language of the host country. So we have, and even the interpreters, they didn't work most of the time, they require very long time, even to arrange to find an interpreter and to arrange an appointment. And also most of the time the results are not satisfactory because there are a lot of, it's uncertain, you don't know if the interpreter made the proper translation of what the patient was saying. Sometimes the interpreter, they tend to maybe have their own perspective, so they try to reinterpret what the patient report or wants to say, so it's very difficult. So we thought that, well, maybe that we need to have a more communication between clinicians that speak different languages. And so this, while talking with colleagues, the idea came up, and so I talked then to the IT people and people in computing science, and I said, what about if we think about maybe something to put together, liaise, maybe health professional, and use these, especially nowadays that we use more these digital technologies. And this came about and said, oh, let's try. So we had just a small fund to try these, and also we presented in a few conferences abroad, and was very, very well received because everyone from different countries, they said, oh, fantastic idea. So we are trying to finalize this and to launch in a proper way, because I think that is a problem that is common in many countries.
Yeah, no, very good point. Nessa is asking, are the assessments recorded? Is there potential to be added to the health record for the individual patients?
At the moment, they are all the information in the platform are anonymized, so only the clinician have the information on their own record, and all the stuff that is because of course there are issues about confidentiality issues. But and so I don't know, at the moment it's just the clinician that wants to, the original clinician, say the UK clinician that wants to identify a clinician that speaks the patient language, that has all the record and information. So everything that the other colleague upload on the app, on the digital platform, is anonymized, and only the UK clinician has this the right information.
Yeah. It's wonderful. I mean, I haven't been in academia until not long ago. I mean, I can see potential networking that you're doing, you know, and the potential to work with people in different countries and different languages, and how that could grow. Are you taking it further from pilot? Have you managed to get funding to do more?
We are trying now to decide the best way to launch, whether to have funding to do a proper, or whether we try, and we start the conversation also with the Scottish government, for example, to explore possibilities. And so we are trying to explore different kind of possibility at the moment, the best way to use this, because of course we can, as you said, it's something that can grow very rapidly. So we need to know exactly
definitely
how we can manage this, and we need to discuss with the right people the best.
I'm glad to hear, despite current economic climate, you still get to go to conferences, because it's such a networking opportunity. It's when specialists are together, and the whole reason for doing it, like these talks as well. So that was really interesting, Miriam. I'm delighted to hear it. And last but not least, Tess, it's over to you.
Great, thank you very much. Give me a moment to share my screen.
Yeah.
Can you all see that okay?
Yes, that looks brilliant.
Great. So hi everyone, thank you all for having me, and thank you Katie for facilitating these presentations again. My name is Tess Watt, and I am a PhD student in computer science at Heriot-Watt University, which is in the lovely city of Edinburgh. And today I'll be presenting my work, which has quite a long title, Moving AI-Powered Healthcare Systems for Skin Lesion Diagnosis to Constrained Devices, which basically means how to put large models onto small devices to diagnose skin conditions. For a bit of background, studies show that AI shows promise for medical image analysis, which could in turn improve patient outcomes, which is super important as the rapid increase in the number of medical images being produced in recent years means that medical professionals are struggling to keep up with the workload. And developing AI systems that can automate time-consuming processes, such as diagnosing skin lesions from patient images, could help to solve this problem. AI assistants are super important and instrumental to the healthcare domain. However, AI assistants often require an internet connection to function, which limits their use cases. And this is a huge issue, as the United Nations conducted a study which found that an estimated 37% of the world's population has never used the internet, with most of these people being in Asia and Africa. And as we all know, being unable to connect to the internet or even having intermittent access means being unable to access data from the cloud. And as I'm sure we're all aware with the rise of AI, that the latest and greatest platforms are being hosted on the cloud. And that's where constrained devices comes in. Constrained devices such as Raspberry Pis, and I actually have one here, this is what they look like. These Raspberry Pis are designed to work offline. They're low power and low cost, which makes them ideal for use in remote areas. And this presented a really exciting opportunity to make an AI-powered healthcare system that is accessible to people in remote and low connectivity areas. I'm often asked if smartphones can be used as an offline constrained device, and technically they can, but smartphones are still not globally accessible, contrary to popular belief. For example, Sudan's smartphone ownership per capita is only 0.2, meaning only around 1 in 5 people in Sudan have a smartphone, so this is not the way forward. Furthermore, Raspberry Pis have already been shown to help democratize healthcare in Africa in previous studies, and my work builds on this by focusing specifically on the diagnosis of skin lesions, because a lot of work is being done on using X-ray and MRI data, but not enough work is being done on looking at skin lesion data. So I'm just going to zoom into one of my images here, which shows my setup and how I managed to achieve this. The answer is I used TinyML, and TinyML stands for Tiny Machine Learning, which in a nutshell uses tiny devices like Raspberry Pis to deploy large machine learning models. And the image that you're seeing on the screen here is the full system I developed. I trained a neural network on open source skin lesion data and deployed it to the Raspberry Pi. And to demonstrate how the system could work on real patients, I attached a webcam to the Raspberry Pi and pointed it at skin lesion images from the NHS website. And in this example here, I'm pointing the webcam at an image of a patient with acne. And on the right-hand monitor, the user interface is telling me what lesion the AI has predicted the patient has. And if we look at this image here, that's a close-up of what you would see on the screen. In this example, though, we're looking at a patient who has melanoma. On the right side here, the system is telling me which skin lesions the AI has predicted that the patient has. And the top result here shows that the system thinks there's a 95% possibility that this is a melanoma, which it is, it was correct. And this demonstrates the usage scenario and helped to lay the foundations for a realistic testing environment, which I am hoping to use in the future. I've actually just applied for a grant to do a joint project with NHS Tayside, where we can hopefully trial this system out in GPs and pharmacies in rural Scotland, which is very exciting. If I scroll up here a bit to our results, our model achieved a highest accuracy of 85% when trained on a dataset called ISIC 2020, which contains around 23,000 skin lesion images. And this sounds impressive on the surface. However, upon further investigation, it was found that this data wasn't actually very well balanced, meaning it was likely that the model was very good at predicting certain skin lesions, but not so good at predicting others, purely because the dataset contained more images of certain skin lesions. Say, for example, it contained thousands of images of melanoma, but only 10 of acne. And so it wasn't equally split as it should be. And this is something that I am investigating further and I'm going to address in my next paper. So stay tuned for that. I'll be sure to be back to present that one. Regardless, this study demonstrated the viability of these kinds of systems and how they could be used in remote areas. Thank you all very much for listening. I believe Katie and the team will be sharing the full poster and materials with you all, and I'm happy to take any questions.
Yes, that was beautifully presented, even more powerful than it was before, and just a tremendous study. The really high percentage of appointments in the UK are taken up with dermatology.
Yeah.
So there's great potential here as well as abroad.
Absolutely.
But fantastic to see you using cheap devices, not your lovely laptop, but your Raspberry Pi, and working on it. And yeah, amazing. And you've clearly got plans for the future too. Sharon's got a question.
I love the presentation. Well done.
Yeah.
Wondered about the bias within the data set in terms of skin tone. If you are thinking about using it in Africa, how will you address that kind of bias?
Yeah, that's a very important question. Currently, the issue is there's very little open source skin lesion data out there. And unfortunately, a lot of it is biased in terms of it being white skin tones. So one way we're trying to address this is to partner with hospitals. Like for my rural Scotland study, I'm partnering with NHS Tayside, and when we come to do studies in Africa, I'll try to partner with local hospitals there to get the, very local demographic data.
So do I understand that when you do the trial in NHS Tayside, it will still be biased towards white skin color?
Yes. However, I've not seen the data that NHS Tayside has yet. It may be more diverse, but it's something we have to look at and balance. And unfortunately, we just don't have the wide variety of data available at current.
Fair enough, and I appreciate that that could be a limitation of the results when you present the results. Thank you.
Thank you.
Are you in touch with any African countries around this, Tess?
Not yet, but there's a lot of research going on into this kind of areas. As I briefly touched on, Raspberry Pis are being used in Africa for a lot of diagnostic scenarios.
Yeah.
So it's definitely on the cards for the future, yes.
Yeah. And would you do all of this research remotely, or do you envisage a visit?
I would like to go on a visit, funding dependent.
Yes. Any particular country you'd like to focus on?
That's a very good question. Somewhere in West Africa would be very useful.
Yeah, yeah, like the Ghana.
Yes.
Yeah. I mean, I'm sure at Heriot Watt there'll be people who have connections back to these countries. So it's worth growing your network and just putting it out there. And I'm sure your supervisors help you to do this. So actually send it round to other schools within the university, because the crossover is quite remarkable when you actually start doing that networking part, even within your own universities. Yeah,
Katie, you were
and
saying,
there'll be routes.
sorry, you were saying, Katie,
Yeah.
that dermatology is one of the highest referrals to GPs.
Yeah.
Interestingly enough, in cruise ships, dermatology is the highest complaint that needs to have addressed. Yeah, and that's where telehealth was effective. So, Tess, if you want to go for a around-the-world tour with your Raspberry Pi, think about it too.
Fantastic.
We're full of bright ideas, aren't we? Yes, encouraging people to do PhDs and then to go on great big trips as well. So any other questions for any of our presenters? Jen's had to scoot away, but you know, we can think back over the other posters. And yes, please do come along next year to DigiFest25, Nessa. 25. And hopefully there we do have a student whose homeland is in Sudan, and she's working with adolescents and mental health. So that she's been tracking that through her PhD at DigiFest, and it's tremendous to see each year on year. So we do invite you all to come back. And as I say, the quality this year was exceptional, really high standards. It was we'd more sort of 7 and ups out of 10 than anything else. It was very skewed demographically that way. So yeah.
I wanted to ask Miriam, if I may. I'm sure the issue of governance, and I think you talked about the fact the anonymized data, but in essence, what you're doing is you identify a patient or a person that needs assessment, and then you share those details with the clinician out with the UK. Did I get that right?
So the app, the digital platform gives you a data set of available clinicians, and they are organized by country, by language that they speak. So the clinician, if you are a clinician in UK, you can contact this an health professional, and this health professional remotely will see the patient, your patient.
How do I know the credential of that remote clinician? This is my patient, or the person I have responsibility for, and in a way, I'm passing on the fact that I'm suspecting a possible diagnosis to somebody who I don't know, and the only reason I'm doing it because they can speak Polish.
No, they are all, of course, there is, we need to decide which criteria, and there are some criteria to include, so that they need to be, for example, recognized, well-known.
Certified, okay.
Linked to the Neurological Association, British, so they are all in a clear network of people with credentials. Yeah.
Thank you, that's reassuring, cheers.
Yeah, yeah. But good point, good point. I'm sure it's something that you had to think about and address early days in your study as well. Folks, I think we'll close out there. Thank you so much. You've all done exceptionally well.